Okay, it looks like we're a couple minutes past the hour, so I will go ahead and get us started. My name is Amber Buning, and I am with CSH, and I'm listed here as CSH Events. Everyone is muted on the call because we have quite a large number of people registered, and we expect about 200 or so folks to join us today. So instead of having an audio question and answer session, we're going to do questions through our chat feature. And you can enable chat by clicking the chat icon on the top right corner of your screen. That will open a window on the bottom right, and you can type your question in there and make sure you send to host. That will send your question to me. I will address any technology issues and then send any content questions along to our panelists. If you do have audio trouble, you can chat with me and I will try to help you. You can also click the phone icon with the green question mark to join via phone if for some reason your computer audio is failing you. And then the last resort would be to log off and restart the webcast. Slides and a link to the recording will be available after the event. And I will go ahead and hand it off to Peggy to get us started.
Thanks, Amber. Hi, my name is Peggy Bailey. I am CSH's Director of Health Systems Integration, and I want to welcome you all to today's webinar, Building Effective Managed Health Care Networks, zeroing in on Tri-County, Oregon. As we've been moving forward with this webinar series, we've talked about managed care. We've talked about how health centers are connecting with managed care very broadly. So today is an opportunity to dive deep in how an accountable care organization can work and the relationship that can be built by all of you as federally qualified health centers. First, I'm going to start with a little bit of background on CSH for those of you who are new to us. CSH, formerly known as the Corporation for Supportive Housing, is about advancing solutions that improve the lives of vulnerable people, maximize public resources, and build strong and healthy communities. We are in the second year of our HRSA agreement, where we're grant project where we're working with federally qualified health centers to engage with the larger healthcare system to focus on people who frequently use crisis systems so we can help them access community-based care rather than expensive crisis networks. We've been doing this in a variety of ways. Today, you're participating in a part of our webinar series. We can do direct technical assistance, and we can also do online and in-person trainings. We help set up peer-to-peer networks, so if there's something that you want to learn about that we know one of your FQHC partners is doing really well, we can connect you and maybe set up site visits or phone calls. And we have a variety of resources that you can access at www.csh.org/HRSA-TA. And we want to thank our partners, particularly the National Healthcare for the Homeless Council and HRSA for making this event available. Today's panelists, other than myself, include Rob Houston, who is the Senior Program Manager with the Center for Healthcare Strategies, Janet Meyer, who is the CEO of HealthShare Oregon, and Ed Blackburn, who is Executive Director of Central City Concerns in Portland, Oregon. The way we're going to structure today's call is first, Rob is going to give an overview of accountable care organizations overall, what he's seeing nationally across the country, and the differences between ACOs and other managed care models, and give a hint as to why we picked Oregon to highlight today. Then Janet will be next and talk about the structure of how the health care partners are working together in Oregon and the role that HealthShare is playing. And then Ed will give a specific example from his perspective at Central City Concerns on the role that an FQHC can play in an accountable care organization and his motivation for getting engaged with the ACO from the beginning. And then we'll do question and answers. Of course, if you have any clarifying questions, please send those along, and I will ask them of the presenters along the way, but we'll make sure to leave plenty of time at the end for question and answers broadly. So with that, I am going to pass it off to Rob.
Thanks, Peggy. Hi, everyone. My name is Rob Houston, and I am a Senior Program Officer at the Center for Healthcare Strategies. Just a little bit about our Center for Healthcare Strategies. If you're not familiar with the organization, we are a nonprofit health policy resource center that's dedicated to improving the health of low-income Americans. We primarily deal with the Medicaid programs, though we do work with the uninsured and Medicare, Medicaid enrollees, and other vulnerable populations as well. We focus on the areas of coverage and access, delivery system and payment reform, and integrating services for individuals that need complex care management. Some relevant CHCS initiatives that we're currently working on, we with the support of the Commonwealth Fund, we run a Medicaid ACO Learning Collaborative, which currently works with 6 states, Colorado, Iowa, Massachusetts, North Carolina, Rhode Island, and Washington, to share ideas and best practices and help design and implement Medicaid ACO programs relevant to our, this is the 3rd phase of our Learning Collaborative this year, and relevant to our discussion today. Oregon participated in the first 2 phases of the Learning Collaborative and is actually faculty for year 3. So they're helping bring along some of the other states that want to do some of the similar things that they're doing currently. We are also federal technical assistance contractors under the State Innovation Models Initiative through CMMI, and we work with all of the design and test states on that project. And we also have a number of value-based purchasing initiatives, anything from pay-for-performance to shared savings arrangements. It's all about moving the ball from volume to value. So the most commonly asked question that I have, because most of my work is in accountable care organizations, is what exactly are accountable care organizations? Now, I've actually presented this slide a number of times over the years, and I used to go into this slide and say, like, well, we really don't know what accountable care organizations are yet, but we are really starting to get a good idea now, so I guess I'm not going to say that anymore. You can recognize accountable care organizations by their model, like a Medicare Shared Savings Program model is different than a Pioneer ACO model, is different than a Oregon Coordinated Care Organization. But there are some characteristics that ACOs share. Their primary goal is to hold providers accountable for improving health outcomes and controlling costs. And they share many specific features. There's always a value-based payment incentive. There's many different ways to go about that. There's provider-level financial accountability to some extent, or over time there's a transition to that. There's robust quality measurement. Every ACO program has quality metrics that need to be reported and then are accountable for their performance on these metrics over time. There's data sharing and analysis. Oftentimes ACOs are providers from different health systems or practices, so sharing data between these providers is essential for coordinating care. On the ground care management, instead of a payer level, a managed care organization, the care management takes place at the provider level. And many ACOs, especially in the Medicaid space, are further collaborating with their community. There are organizations that have community involvement on their governance structures, on their board of directors, and there's various models to engage the community as well. So how are ACOs different from other payment reform models and managed care? They represent a major shift from fee-for-service payment, and they're distinct from other health reform models as well. Like I alluded to in the previous slide, managed care models, the care management, care coordination level is at the health plan level. They don't have hands-on contact with the patients as much as the providers on the ground do. So the ACO model aims to shift the accountability for those care management services and the care coordination efforts to the provider level to incentivize them to provide better care coordination. It also provides value-based payment models and quality incentives. Patient-centered medical homes, they may measure quality, and health homes measure quality, but in general, they're paid through an upfront per member per month care coordination payment, and they're really not as accountable for outcomes as ACOs are. That many times the shared savings or other kinds of payments that are offered for ACO arrangements are contingent on meeting a certain benchmark in quality performance. Otherwise, they either don't get a chance to share in savings at all or receive a lesser amount of shared savings back. ACOs also generally focus on large patient populations. This is different than health homes models because the health homes usually serve complex patients. While ACOs do target super utilizers and people with complex care needs, they, due to the potential of cost savings and improved performance, they serve a much larger population in general. So what type of ACOs exist? There are Medicare ACOs. These were kind of the first ACOs to hit the ground running. Pioneer ACOs, Medicare Shared Savings Program ACOs, and CMS recently rolled out next generation ACOs, which will be starting in 2016, that will take on more risk or offer the option to take on more risk and become more accountable for quality metrics. Commercial ACOs, there's a lot of them out there. I refer to them as the wild, wild west of ACOs because they're largely unregulated. There's no federal guidelines on this. As long as the ACOs that enter into contracts with managed care organizations don't run afoul of antitrust or collusive practices, there's not a lot of guidance on how these models work. So you get a lot of very creative models in the commercial sector. These are largely led by health plans and hospital systems because the hospital systems have the size and the patient populations to take on some risk. Though there are some arrangements that are with multi-specialty provider practices, federally qualified health centers, and other provider organizations as well. Medicaid ACOs are what we're going to focus on a little bit more today, and there are 9 states with Medicaid ACO programs up and running, and at least 10 others are pursuing programs as well. And this next slide shows where the Medicaid accountable care organizations are occurring. The states that have that are in orange have a state-based Medicaid ACO program, and the ones in that light blue color are pursuing Medicaid ACO programs. There are many more than the states in the light blue that are interested in pursuing, but the ones in the light blue have taken some concrete steps down the path towards ACO activity. It should also be noticed that Medicaid ACOs exist in many, many more states than these shown, but these are the ones that have a state-regulated program. There's, for example, there's many Medicaid ACOs in California that have arrangements with their Medicaid MCOs, but they really don't have anything in terms of, there's no state regulation or certification process that exists for the state of California at this time. So how are CCOs different than other Medicaid ACOs and other managed care models in general? So Oregon's coordinated care organizations are possibly the most advanced ACO model. They were authorized by an 1115 waiver, and there was a lot of things that are different from an Oregon model than the other ACO models. There are 16 geographically based organizations. You can see them in the map on the right side of the slide there. And one thing that's unique is they are payer-led models. Now, before I mention that there's a lot about a big part of the ACO model is shifting the accountability down to the provider level, and if these are payer-led models, how does this work? There's active participation of provider organizations in the board, and I believe our other presenters will get into more detail on that, so I'm not going to try to preempt them there. But that is one of the key focuses of the coordinated care organization model. These organizations provide physical health services, like all ACO models, but they also provide behavioral health services and dental services. Dental is unique among Medicaid ACO models as a required service, and they serve Medicaid and Medicare Medicaid enrollees. For the duals, it's just the Medicaid services for those enrollees. Providers and CCOs are also accountable for performance on 33 quality metrics, and there is a quality pool of the payment structure that is withheld to enforce those metrics. The payment approach of the CCOs is also really unique. Because these are health plans, these are run by health plans, for the most part, they're used to taking on risk more than the average provider-run ACO. So they're paid on a capitated basis through a global budget, and it covers the scope of services that physical health, behavioral health, and dental services that we had there. But they also cover some other interesting services as well. Patients are also geographically attributed, which is unlike many Medicare, commercial, or other Medicaid ACO models as well. If a Medicaid or Medicare Medicaid enrollee is in the geographic area, they are attributed automatically to the CCO, and the CCO is responsible for their care. I mentioned that the quality incentive pool rewards performance on quality metrics. Some of that global payment is withheld and sent back to the coordinated care organizations at the end of the year if they meet the quality metrics. CCOs are also encouraged to use alternative payment methodologies to providers down from the CCO level, so that the providers have either a shared savings arrangement or some kind of capitated model or a pay-for-performance model, so that they're not just being reimbursed fee-for-service under that CCO global payment. CCOs are also able to pay for flexible services, which are not typically covered by Medicaid. The examples that we use are air conditioners and air purifiers as well. Using these flexible services are at a CCO's discretion, and they decide whether or not they want to institute these or other services, and the state really encourages the CCOs to be creative about how they want to pursue this. One guideline that the state gives and the 1115 waiver is it cannot be a service that's already reimbursable by Medicaid, so it has to be something outside the box if it's going to be paid for with flexible services. So the Medicaid ACO results to date, some models have seen some good success. Other models are pretty new and they haven't reported any cost or quality savings. But the 4 states that have reported results have done a pretty good job at saving money and improving outcomes. Colorado has a $35 to $39 million in net savings over 3 years. Minnesota saved $76.1 million over 2 years. Vermont saved $14.6 million over 1 year with only 2 ACOs. And Oregon's results are primarily utilization. We don't have exact cost numbers that the state has provided at this point, but ED visits declined 17% overall, decreased hospitalizations 27%, for CHF, 32% for COPD, and 18% for adult asthma over the 2 years of the first 2 years of the program. And they haven't reported exact cost numbers, but the 1115 waiver says that they have to stay within 2% cost growth rate mandated by the 1115 waiver. The CCO program has been able to do that, though it seems that the CCOs have variance in the actual cost savings that they have achieved. They vary quite a bit from CCO to CCO, as could be expected. So I'll pause to ask if there's any clarifying questions that folks would like to ask. Any kind of discussion questions we'll save till the end, but if there's anything that has direct impact on the information that I presented, I'm happy to address those now.
Yeah, Rob, this is Peggy. There's one question that to help folks that may not have an ACO model in their state, but want to ask, just overview of how can they, what should they, as they listen to Janet and Ed, what are those things that are similar with any other managed network, like a health home networks or managed care networks?
Okay, so the similarities is it's all about care coordination. So like I mentioned before, the care coordination is done at the provider level more, and that's similar to a health home because the health homes do have care coordination entities, but the difference between a health home and a ACO is really the population focus of the large population focus of an ACO, and typically there's cost savings that are attributed to that. The performance outcomes on cost is something that's directly attributable to provider reimbursement on an ACO model. If you're asking about the how, if there's no state-based Medicaid ACO program in your state, a provider organization can just contract with a managed care organization if there's managed care in the state. So, if you're an FQHC that would like to enter into an accountable care arrangement, it gets tricky with prospective payment and how that works with, say, a shared savings arrangement. But you can contract with an MCO to provide certain kind of performance-based benefits on that. If you're in a fee-for-service environment, it gets a little tougher.
All right. Okay. All right. Thanks, Rob. So now we'll pass it on to Janet.
Hi. Thanks. Good morning, everybody. This is Janet Meyer, and I have the great privilege of being the CEO of Health Share of Oregon. We're one of 16 CCOs that operate in our state and focus solely on the Medicaid population, which we call Oregon Health Plan in our state. So the origins of Health Share, I want to put some context around that. Managed Medicaid has a very long tradition in Oregon. There was already a managed Medicaid mindset, infrastructure, and even more importantly, our state agency that governs our Medicaid program had a deep history in managed care. So that helped us as we moved towards this more global, integrated type of organization. For our particular service area, there were 5 physical health plans, 4 mental health plans, and 8 dental health plans operating in the metropolitan area doing managed Medicaid. And it was really our governor and the director of the Oregon Health Authority who challenged the leadership in our service area to think about a different way to do managed Medicaid in the greater Portland area and to really try and create something different and new. We had legislative guidelines, and we used those to build the company, but it really was a great leap of faith by our founding members to stay at the table and try this new structure. It was predicated on the idea that this is an entirely new paradigm, and we really need to create a new structure. And, as one of our board members said, what's transformative is to create something that doesn't exist, and they really did that with this organization. The other thing I would add is that we are legislatively required to have our CCO governance structure reflect the community in which we operate. Some CCOs have very simple structures. We're in a very complex market, and our CCO has a more complex structure, but all the important parties are at the table and work together on this transformation. So some facts about HealthShare. We're a tax-exempt, not-for-profit charitable organization. We have a 20-member board of directors. 11 of those directors are member directors, part of the founding organizations, and we have 9 elected directors. We're required to have a consumer on the board, and we have an Oregon Health Plan enrollee on our board. We have a full-risk capitated contract with the state for HealthShare. That's about a $1.2 billion contract in terms of annual revenue. HealthShare is the largest CCO in Oregon. We represent about a quarter of the Medicaid enrollees in the state, and we have a large network, 16,000 providers in our network. This slide shows our founding members, and I'll take a minute here to talk a little bit about this. One thing you'll notice is we have 3 counties that operate in our service area. All 3 counties have a seat on our board, which makes for an interesting dynamic because of the, the open meetings and the public records that we have to have a lot of transparency because of that. And that's a good thing. In Oregon, traditionally the counties manage the mental health Medicaid program as part of their role as the local mental health authority. So we have 3 counties. We also have 6 delivery systems. In our market, we have 6 large hospital systems. They employ a lot of physicians, Adventist, Oregon Health and Science University, Providence, Kaiser, and then Tuality. So we're very fortunate, and for the most part, it's the CEOs of these large institutions that sit on the HealthShare board. And I'll point out the obvious. These are fierce competitors in other markets, in other segments. But for Medicaid, they've really come together under this HealthShare idea to move the mark and improve outcomes and a little bit smarter spending in terms of the Medicaid population. Central City Concern is a large, and Ed will talk about that in a minute, a large provider of services to some of our most vulnerable citizens, by and large all Medicaid or uninsured. And then Care Oregon is a long-standing managed Medicaid plan, and they are also founding members of our board. So it's an interesting collection of people. It's been a really rewarding experience, and we're very fortunate to have those founding members support us. So our operating model, many of you are familiar with collective impact, and that's really how HealthShare was envisioned. So we're not a payer in the traditional sense. We're not a health plan. The board doesn't believe that managed care plans are going to transform healthcare necessarily. That's really not what they're structured to do. So HealthShare has been set up as something of a hybrid, and if one way to think about it is it's a bit of a superstructure over other organizations below us. But that puts us in a good position to provide a backbone organization under the collective impact model. So we work very carefully with our partners, our stakeholders in the community, and our board on making sure we have a common agenda. We've agreed on measurement. It's been very rewarding to do this work. We've gone out of our traditional, we meet with people that we wouldn't have traditionally met with, United Way, school districts, and all the different community-based organizations that also serve our members and also impact their health. So this collective impact model has proven to be very powerful here in our market. We also use a framework based on centralize, standardize, and align. So we don't centralize everything at HealthShare. Some things we think are better done closer to where the patient care is being delivered. Some things make sense to centralize, such as ID cards and member handbooks and so on. Some of our protocols we standardize, and it's just for sanity purposes, I guess. We try and say, look, we're all going to do it this way. If it's a HealthShare member, they're all going to have a standardized experience, and this is how it's going to work. And we manage the politics by developing policies, collaborative policy making. Some of our initiatives we don't dictate to our partners. We just align around a vision. A good example would be reducing ED visits. We want to reduce ED visits. Different systems can approach it in their own way that's consistent with their business model. But we're aligning around a goal and then having flexibility to achieve that goal. We look for administrative efficiencies. We haven't put a lot of emphasis on that because, quite frankly, when you save money in administration, you're saving maybe pennies, and if you're saving money in medical spend, you're actually saving dollars. So we haven't put a lot in that, but we do try and think about that, particularly the burden it puts on our providers. We work actively enhancing community engagement at HealthShare, and we serve as an integrator and a convener in that regard. And then we make transformative and strategic investments regionally for those, especially for those populations that are better managed regionally. And a good example are the foster kids. So kids in foster care, there's about 3,500 of them on any given day in our population, and that's really a population that is better served with a regional strategy. So we make strategic investments around a regional strategy on special populations. Another example are women with substance use disorders who become pregnant, and we take that population and take a regional approach and a regional investment. So I was asked to do this structure of HealthShare, and I don't want to frighten everybody, but I'll roll it out as evenly as I can here. The first thing is we currently work through 4 physical health partners. Each partner has a unique primary care network, and that's really the criteria for taking a risk contract with HealthShare. You have to have a unique primary care network. Kaiser, Providence, and Tuality are integrated delivery systems, and they operate, Kaiser and Providence operate on a total cost of care model, so their providers are put at total risk for performance on the Medicaid contract. Tuality has a hybrid approach, and Care Oregon works largely with the FQHCs. They are a network model. They're not an integrated delivery system, and they are exploring alternate payments with the FQHCs, but they are largely still fee-for-service. Let me see here. Our mental health is managed out of our counties currently, and that was a good move when we opened our doors. It's time to make some transformation. So in July of 2016, we're going to a regional strategy that will integrate addictions and mental health funding. We'll still leverage the county's skills and experience in care coordination, case management, and particularly in system development. But there really is one regional specialty system of care in our area, so we're going to treat it as a network that's regional. And that will be, I think, a good improvement in terms of efficiencies and in terms of improving outcomes. Our dental partners were legislatively mandated. We didn't have an option. We were required to contract with whoever was operating in our service area at the time Ccos were invented, and we have a large collection of dental health plans. Some of them are very small. We believe that sometime in 2017 we'll develop and articulate a strategy for managing this wide variety of dental partners and getting some improvement in outcomes by doing so. And then the last thing is HealthShare operates a non-emergency medical transportation benefit. We have a broker that handles it. HealthShare takes the risk on it, and we provide non-emergency medical transportation for any appointment, whether it's mental health, dental, physical, trip to the pharmacy, and so on. So that's HealthShare. It looks complicated. If you're inside of it, it makes sense. If you're in our market, it makes sense. But I recognize that it may not be as elegant as some might have thought. So how are we doing? So as part of our waiver, Rob mentioned that we have a limit to how much our annual rate of increase can be. We're limited to a 3.4% annual rate. Now that's for the state as a whole. That's not for the Ccos. The Ccos are a big part of that, but our average rate increase has been more in the 2% for the last, we're 3 years old now, so we're at about a 2% average. So we have to be held to that, and we have to figure out how to keep our spending under that. And as Rob also mentioned, a larger percent of our premiums come in the form of quality incentive payments based on 17 metrics. There's a total of 33 metrics that we're evaluated on, but 17 of them actually have dollars attached. And when we started, it was, the first year it was a $13 million pool of money for HealthShare. Last year it was 34, and this year it's up to 45. When you're getting up to that kind of money, you do get people's attention on focusing on those metrics. ED visits are down. Developmental screenings are up. The metrics are generally going the way we want them to go. We've got a big push on reducing readmissions, all the right things. I gave the web address for all the CCO performance metrics are available online. I think where we're at right now and the dilemma we have, it's actually two dilemmas. One is I think we're realizing that the savings are in upstream prevention and more of a multi-year approach to chronic disease management. That means the return on investment is in the future, but we're under pressures to save money now. You can only save so much money by better management of quote-unquote high utilizers. There's only so much you can save, and we're already a pretty efficient Medicaid market. So we're right at this nexus now in terms of one of the best things we can do for our population is get kids ready for kindergarten. And the benefit to that accrues out in the future, not today. So it's an interesting spot to be in right now. And but we're not shying away from the challenge. The last thing I would say, the last dilemma we're in, is even though we're under an 1115 waiver, the federal government still has a lot of actuarial anxiety about us and what they've approved for us to do. So on the one hand, they say, we want you to transform healthcare, alternate payments, and so on. But on the other hand, they say, you have to demonstrate in an actuarial manner how you're spending your money. And those are really contradictory directives. So we're working with CMS collaboratively. It's not slowing down transformation, but it's reminding us that we're a bit on the bleeding edge as it is with our CCO experiment out here. And that was what I had. I'm happy to take questions. Turn it over to one of my favorite board members, Ed Blackburn.
Hey, Janet, I had one clarifying question that I wanted to ask, and that is, you know, when you're talking about the incentive pools, you know, what, and that there's $45 million in incentive payments, out of what total spend is that?
Our actual medical budget is around $750 million. So.
Okay. Great. And then and then one thing that you mentioned about the mix, that you have some fee-for-service, some capitated delivery. Does that present any greater or fewer opportunities for cost savings?
You know, I think we have to meet the providers where they're at and where they're ready. And some systems are more ready than others. And, you know, we have, you know, we can't break anything in this process. We have to keep the system operating and keep the patients being seen. So we're willing to work with the providers and meet them where they're at and move them along. And it's not ideal to have as much fee-for-service as we have, but we're still improving outcomes. We're still changing the experience of care, and I think we're seeing smarter spending, even though it's on a fee-for-service model.
Okay. Thanks, Janet. There'll be more questions in the Q&A. So we can pass it on to Ed.
Well, thank you, everybody. As Janet mentioned, we are a founding member of HealthShare of Oregon. And so the reason I think that we were asked to be there in the early formation of a steering committee that was exploring the idea of becoming a coordinated care organization with most of the entities that have been mentioned was that the area FQHCs asked us, Central City Concern, to represent FQHCs on this steering committee. And I want to say from the outset that the experience here at HealthShare in terms of the relationships with FQHCs has been very accepting and very supportive. So our experience here might, you know, I'm sure other FQHCs are being engaged in other places, but in Oregon, I think the way HealthShare involved FQHCs from the beginning is pretty unique. Central City Concern is healthcare for the homeless entity. So we provide integrated care model with specialty mental health and specialty addictions services embedded in our healthcare for the homeless FQHC. And currently we have about 7,000 patients, represent a very sick or high acuity population compared to the general Medicaid population. It's also important to note that we own or operate about 1,600 units of housing. Some of that is special needs housing for people with mental illness and addictions. We also have access to about 200 scattered site-based rent vouchers in the open market, where we're providing housing first options, and we also have recovery housing within our housing portfolio. And we've been in operation with housing for about 36 years. In addition, we do income and employment support. So we have what we call the BEST, or Benefits Entitlement Service Team, that does an expedited SSI benefits acquisition for people who are disabled. It's very robust, and we've probably gotten 2,000 people signed up in SSI benefits in the last few years. And then we also do supportive employment models. So we have a center, an employment center, where we do training and education, but we also place people in jobs in the community, and are averaging about 500 placements a year through our employment. So that's the background of who we are. I've talked about the housing, and I've talked about the health care. In terms of our involvement with HealthShare, it's been from the beginning, before we were actually founded as a coordinated care organization. I thought in the beginning my role, besides representing the FQHCs in the formation of HealthShare, was also providing information and some education, and also helping to build relationships with the CEOs of the large healthcare institutions, with other community-based providers in the community. So that included specialty mental health organizations, addiction treatment organizations, and other anti-poverty organizations in the community. And I want to say from the very beginning, and Janet played a big role in this as a convener of organizations throughout the metropolitan area, to give them a platform to interact with the large healthcare organizations. And I think that was a very enlightening experience for both sides. And a lot of that relationship building in the beginning has paid off for community-based organizations who are now getting more direct support and coordination of care with larger healthcare institutions. I think that I've also played a role as a officer on the HealthShare board, vice chair of the finance committee, and for the last few months, vice chair of the board. And so the culture of HealthShare, I think, nurtured that kind of strong community connection, but also very open and welcoming in terms of the leadership of the organization. There have been practical, very practical results in this. It was mentioned the decrease in ED visits, the decrease in hospitalizations. So we've been very active on that front in terms of helping to design and implement clinical responses to people who are high utilizers of those systems. So our chief medical officer has been very involved in helping to design interventions with other clinical leadership through HealthShare. Also expanding access to medication-assisted heroin treatment, particularly Suboxone, throughout the community. We've seen now much more access and capacity on that level being developed, and I think the plans for the future are even more development around addiction. So we're very excited about that. And there's also it's been a lot of interaction for us with the entities of HealthShare. An example of that would be we have been in the process for the last 2 years of developing a complex care model at our Old Town Clinic, and it is actually funded by Care Oregon and a couple of other entities to set up an ambulatory intensive care unit, as well as to build up our team-based care to do more outreach out into the community in terms of doing home visits. So we've seen a lot more support for homeless populations and for populations in poverty coming directly from HealthShare entities since this got off the ground. So it's had a high impact on us, and it's an exciting time. I think some of the difficulties are still the complexity of the healthcare economics and regulatory atmosphere. We are moving towards an alternative payment methodology. Several FQHCs have already made that transition. We were asked by the Oregon Primary Care Association to wait till the end because of our complex care delivery, including the addictions and the specialty mental health. But we are also moving in that direction. And we hope in the future, and we're seeing some movement around flexible funds that will help us do more of the kind of non-Medicaid reimbursed services that need to be done if we're to be successful with the homeless population. So with that, I will end and see if there are any questions.
Sure. Thanks, Ed. Ed, could you do me a favor and pass the presentation ball to me? Because I wanted to ask you the first question, and I thought that moving the slide to one of Janet's slides would be good.
Okay.
So the first, and this question for Janet and maybe Rob, in thinking about the audience on the phone are mostly federally qualified health center providers. So in this organization chart of how HealthShare works, can you talk a little bit about the entry points for the providers, particularly I think from what you said, Care Oregon. So, you know, with Ed as the example, he has a direct relationship with HealthShare, but he's also entering into through conventional mechanisms that are probably replicable in other parts of the country.
Yeah, so actually Care Oregon, Providence, and Tuolumne all have federally qualified health centers. One of our dental plans is also federally qualified health center-based dental plan. And all three counties, it's interesting, all three counties, well, two of the counties operate federally qualified health centers, and so it's a overlapping role that many of our partners play with us. The federally qualified health centers here in Oregon are working on alternate payment, and you know, it's a process. It's complicated with them because of the wraparound payments.
Right.
I'm not sure what.
Right. No, that's great, because that's what I wanted to highlight, or the entry point. So if you're an FQHC out in the world and you want to engage with your accountable care organization, there's the organization entity, but there are also the entry points, the people that the organizational entity is working with that you probably typically work with already as other entry points, because I think what we've seen across the country is, and in Ed's example, is the proactive nature of engaging with the system. So it's just important. I wanted to highlight what the entry points were.
I think there's something unusual also in Oregon in that, by and large, the majority of private practice providers take Medicaid in Oregon and have for many years. Only about a third of our Medicaid enrollees statewide are served through federally qualified health centers. And that includes through the expansion population. So I think we have a slightly different marketplace here for serving our Medicaid enrollees as well.
Great. So Janet, and then maybe Rob, you can talk about how this works nationally. But obviously, you've talked a lot about the savings that you've achieved in the system, and folks want to know, how those savings can be spent. So we've gotten a few questions about around one, Janet, for you, what are some of the things that you've been able to use those savings to reinvest in? Among those are things like housing or rental assistance or other social determinants of health, things that you're allowed to invest in? And then, and Janet, go ahead and answer that, and then I have a follow-up question directly for Rob around that same topic.
Yes. Through our waiver and through our flexible benefits, we can authorize payments for housing, authorize payments for, air conditioners, all sorts of things if it's going to improve the outcome or save the funding, make it a better financial decision. So we have that flexibility. Again, I would say that there's a little bit of conflict in the feds in that they want us to do these flexible services that we know will improve outcomes for our clients, but they get really nervous when we do it. And they, housing's a good example. On the one hand, we know that housing has a direct relationship on your health, and yet they say, but you shouldn't use Medicaid money for housing. So in Oregon, we're working it out, but we still have a little bit of work to do with the federal CMS part of it.
Ed, do you have anything to add to that before I ask Rob about from a national perspective?
Well, there's a number of ways in which housing is important, but there's also different ways in which the healthcare system can interact with it. So we do receive funding support for assertive community treatment, for intensive case management, supportive housing services. We do receive support for respite care program that we have called the Recuperation Care Program. Those things, in terms of the support services and some very short-term rent coming out of other dollars that health systems have access to, we do and have been doing. I think on the rent assistance side, it's still, it's still early stage, but there is, with this cap on how much we can grow in terms of our Medicaid dollars, we're in this environment where it's very difficult to for some Medicaid entities to envision that money being used for things like rent subsidy and other housing, kind of that end of the housing issue. I do want to say that a number of the entities of HealthShare have changed their community benefit. What things they can do with what kind of funding choices they can make with the community benefits to include capital contributions to housing projects. I think, although they're doing that separately from HealthShare, this wouldn't be happening if HealthShare hadn't created the stage for the dialogue between housing providers and these healthcare entities.
Great. Thanks. And just to follow up on one quick thing, and Rob, I promise I'm not just teasing you, I'm going to ask a national question around this one, is how, when we talk about rental assistance, and I know it being short-term, Janet, is there a set term on what short-term means?
No, not at this time. It's
okay.
Up to the partner to determine what is a reasonable subsidy.
Okay, great, thanks. So Rob, you've heard this nationally. Do ACOs really have this greater flexibility that, maybe managed care entities or health home networks don't have, and are there any other examples that we should know about?
So ACOs in general, it really depends on the program. Some have authority to pay for certain services, some don't. It really depends on what their scope of services is. No Medicaid ACO program has explicitly included housing under their scope of services in which their shared savings arrangement or their capitated payments are tied to. However, Hennepin Health is my favorite example of this. There are reinvestment funds in Hennepin Health that say it's a county-based pilot authorized by state legislation. So and it's separate from Minnesota's ACO program. They participate in the ACO program, but the Hennepin Health pilot is something separate outside of it. So it is an ACO. They receive a capitated payment, a global payment like Oregon Ccos do, but the one thing that there's something different about their capitated payment because it has braided social service funding. So what that means is they have funding going into the organization, and the Department of Social Services is a partner in that organization, as is a hospital, as is an FQHC, as is a health plan. And they can, the organization can direct the social service funding to social service things. It doesn't mean that it could be the social service money can be used for a Medicaid purpose, or Medicaid money can be used for a social service purpose. That's what braiding means, because it has to follow where that the funding stream has to pay for those services. But the providers get to have an input and to where housing could be a good prescription. That being said, if they save money under their PMPM global payments, part of the savings is paid out to the partner organizations. Part of it goes into a reinvestment fund. And what Hennepin Health has done with their reinvestment fund is provide permanent supportive housing for members, for their members, and they've seen really good results in terms of ED usage and inpatient stays as a result of those placed through housing. It's like 70%. I don't want to get the numbers wrong, but I know it's
No, that's great, Rob. So I'm going to ask one more question, and then I'll promise that what we've been doing is taking the questions from the chat and answering them and distributing them out, so we'll be able to get to other questions that were asked. But the last question for Ed, because I think it's important for the audience, is can you talk a little bit about the metrics that you're accountable to for health to the CCO?
Well, we participate in the 33 metrics that Janet talked about. So we have several that, as a healthcare for the homeless, treating mostly adults, that we focus on. So blood pressure control, A1C control, depression. There's a number of things that we are monitoring. And there are things that we do on our own through separate metrics of things we're funded through by the entities. So we held accountable. Most of this is through Care Oregon, and if we achieve the metric, then we get an incentive payment. And I think we met most of them, if not all of them, this last year. So we are accountable. It's not in terms of reduction in pay if we don't achieve the metrics. It's more of the incentive payment we get if we do.
Great, thanks, Ed.
I could provide a list of the metrics we're actually following. So.
Oh, that would be great. That would be great, and we can send that out as part of the resources. Well, thanks, Ed, Janet, and Rob for presenting today. We know you're all very busy, and this takes time out of your schedules, and so we really appreciate it. We'll send, as I said, we'll send out other resources, and always watch our website that's here on the slide, www.csh.org/HRSA-PA, for upcoming events and resources. You'll see the next webinar is November 18th at 2 p.m., where we're going to look at who are frequent users and how are we defining them in communities. So thank you, everyone, and have a great rest of your day.